Well, I was invited at ASCO to give an educational talk when I was a young doctor on thymic tumors in 2012. It was very impressive for sure, but I had worked on these tumors for more than 5 years before being invited. We collected some data on patients, real-world data. We generated the first recommendation for the treatment of those tumors. We built a network in France, a network of hospitals dedicated to the management of thymic tumors. We had just at that time set up the International Thymic Malignancy Interest Group. So there was a momentum around those tumors, and ASCO invited a group of us to discuss the management of thymic malignancies. I think it is the only session dedicated to this rare cancer that I have seen over the past 15 years at ASCO. Now, it's really good that in the same old D1, our abstract for the ETOP EORTC NIVOTHYM trial was selected by the ASCO Scientific Program Committee. NIVOTHYM is a phase II study that was conducted in type B3 thymomas and thymic carcinomas, the most aggressive thymic tumors, which are also less frequently associated with autoimmune disorders. We know that this may be aggressive disease, especially at a recurrent or metastatic stage. And NIVOTHYM is a two-cohort phase II study. The first cohort with nivolumab as monotherapy. We previously reported and published these data with a PFS rate of 6 months and disease control rate around 70%. So this was highly promising. And we decided to move to a second cohort with nivolumab plus ipilimumab, so a more potent immunotherapy. Hopefully the safety was good and quite similar to that reported with nivolumab monotherapy, probably based on the experience of our investigators, who were able to recruit a total of more than 111 patients over a 4-year period, including a 12-month pause in between the two cohorts. So it shows how academic collaboration within Europe leads to perform good trials in a rare cancer. And with regard to the efficacy of nivo plus ipi, it's disappointing because the PFS rate at 6 months, which is the primary endpoint, was only 22 months, median PFS 3.1 months. So the addition of ipilimumab is not associated with a better efficacy. Ultimately, what does that mean for the management of patients with thymic tumors? Well, over the past years, we have seen new data in that field. Immunotherapy in the late-line setting is still an option in selected patients, pending close monitoring for immune-related adverse events. But we know that immunotherapy may be combined with anti-angiogenic agents. We saw the PECATI trial at last ESMO meeting with pembrolizumab plus lenvatinib. And meanwhile, in December, we learned from the Japanese MARBLE study with chemotherapy plus atezolizumab in the first-line setting. So many data. We know that those patients should receive immunotherapy, a single agent, in the first-line setting in combination with chemotherapy, possibly in the late-line setting with anti-angiogenic agents. We know that chemo may also be combined with ramucirumab based on the Italian data. So it's a matter of how to sequence or combine chemotherapy, anti-angiogenic agents, and immunotherapy. So we need to continue to conduct trials in this rare cancer population. So I'm not sure that immunotherapy can replace chemotherapy in the first-line setting. The risk of immune-related adverse events is quite high, 30% of the patients, including severe immune-related adverse events such as myocarditis, colitis, and so on. So selection of patient is key, not only biological but also clinical, and a close monitoring. So to me, there is a need to be cautious in the use of immunotherapy in those patients. The next step is to look at treatment sequences and combination. Probably need to compare a sequential approach versus a combination approach. Obviously, it's again a challenge in terms of recruiting patients, especially in the first-line setting, but thanks to the networking, especially in Europe, with a central multidisciplinary tumor board that exists in France, I believe this is feasible.